being here. And, you know, as we always do, I'm going to start by talking about a little bit about where we are with the numbers. But, you know, we're in a time when it seems like every minute brings some new, if not bad news, at least unsettling news. And I really wanted to start with something more positive this morning. And that is, I had the privilege about 10 days ago of going to a couple of our recovery court graduations. And what's been impressive is the way they've been able to continue the recovery court virtually through the pandemic. And, you know, seeing people and connecting and doing all of that. And one of the things that when we think about what's left over from this that we really don't want to lose, one of the things that's been really important and a number of people talked about at the graduations was, given the physical size of Middlesex County, as you know, it's 877 square miles. So transportation is often a very significant issue for people. The ability of people to be able to go to virtual meetings essentially on their own schedule and easily accessible has made an enormous difference for people. So that's something I think going forward, we're going to have to look very hard at, both because of the distance and obviously the cost. In parts of our county, you know, even where there is public transportation, the cost, and especially if you have to bring somebody with you or you have kids you're bringing with you or something, makes that travel prohibitive. So that's an important piece. The second thing that people mentioned was, for some people who are receiving medication assisted treatment, that trip to the methadone clinic every day was really a burden. And the fact that now we've been able to get medication to people, so far as we know, that's gone pretty seamlessly, of people being able to get their medication, take it at home, and still do their job, remote schooling, whatever it is they need to be doing. That's another significant piece. But one of the things, you know, if you have not been to one of those recovery court graduations, they are probably the most moving things that we ever do. Hearing about people's struggles, how it is that they've gone through the 4 phases of that program, often with lots of missteps, but just the joy in how they've been able to repair, excuse me, repair family relationships and get themselves to a different place. And the first one I went to, the graduate, one of the most impressive graduates, was a woman who was, shall we say, very seasoned. I would say she was probably well into her 7th decade. And substances had played a really controlling influence in her life for over 50 years. And the recovery court had gotten her to a place where she was then in a very, very stable recovery. And with her in her house and sharing on Zoom with the recovery were her children and grandchildren, whom she had been estranged from for many, many years, in large part, as she told it, because of her addiction. And, you know, I was thinking about all that we do and all the effort we're putting into things and we're working away, and you never know what combination of things is going to work. And looking at and hearing this woman tell the story of her life was something that I thought, you know, it had taken her just under 3 years to get through the program. Probably 3 years ago, you might have looked at that and thought, after 50 plus years, nothing's gonna work. It would not have been unreasonable to think probably everything has been tried. And she went through this litany of things she had done in programs she had been in. And yet this time the results had been different. So I just found that an incredible validation of all that we're doing and really showing both the tenacity of the human spirit and the improbability sometimes of things working out. So I wanted to just start by talking about that, because I really do think everybody needs that sort of, not only is this work in its normal form sometimes discouraging, but particularly where we are today and so many friends. So turning from that to where we always are, to our numbers, and we see that from the beginning of this year, we've responded to 134 overdose deaths, um, which is still on track to bring us in significantly lower than we were last year. But what is concerning is a number of those deaths, although they are classified as overdoses, were clearly what we're calling death by despair. So the mechanism of death was a substance, but it is clear that there were other factors, socioeconomic factors, that impelled that person to take their life. So that's the thing that we are really grappling with. And we've seen since our last meeting, we've had 24 of those 134 deaths. So it is, I think we've reached a point where people who thought we were going to get through the summer and this was going to be over, and now seeing winter is coming, fall and all of the holiday things are being put off. It's getting dark at 5 o'clock in the afternoon. Things have changed, and maybe economic situations have worsened, and that is taking a toll on people. So that's something we're looking at very closely and really making a push in terms of getting out those kind of connections to services. On the racial justice front, we've talked a lot about what we've been doing in the office. We this week had two of the authors of what you might have seen came out in September, the Harvard study about the racial inequities across the court system. And two of the authors come to talk to our staff this week about that. And we'll be having two of the authors of a study I find very concerning, that being the discipline of Black girls in school and the impact that has on them not continuing. So we'll be having two of those speakers coming on Friday. And we're happy to make that link available to people. I think it's going to be a very interesting presentation. And I also want to talk for a minute about a new partnership that we are in with the Regional Behavioral Health Coalition at Melrose Wakefield Healthcare, the Mystic Valley Public Health Coalition, and the National Alliance on Mental Illness. And on October 20th, we will be hosting a community presentation called Challenging Choices, Difficult Decisions, Finding Strength in the Pandemic, exactly what I've just been talking about, the antidote to that despair. It'll be obviously a virtual presentation, open to everyone who's working with people who are having difficulty, and I think that's everybody, navigating the challenges of the virus. So Nora's going to put the flyer up in the chat. And please share it widely, and we hope that many of you will be able to join us. We've got a very full agenda this morning, and I want to get to our presenters. The first topic we're going to be talking about is cultural competence in treatment. And this is something obviously we've been looking at across our work. The first are our colleagues from the Cambridge Health Alliance. Dia Kelly-Bablea is the Director of Training for the Victims of Violence Program at Cambridge Health Alliance and a trauma consultant in the Department of Psychiatry. She's an assistant professor in the Department of Psychiatry at Harvard Medical School, and her specialty, well needed right now, is the treatment of trauma-related disorder. She is a member of the Task Force for Human Rights of the American Psychological Association and has published in the area of complex trauma, gender-based violence, homicide, bereavement, and refugee health. And joining her is Jamie Ladera, a member of the Community Health Improvement Department at Cambridge Health Alliance. She leads the youth programming with attention to substance use prevention and youth leadership and advocacy. She also oversees Cambridge Health Alliance Mental Health Awareness Training Program. She's a seasoned trainer, and she's been with us before. She specializes in offering mental health first aid and cultural humility. She's worked in community-based settings, urban schools, nonprofits, healthcare environments, and she's an online instructor for BU's School of Social Work, holds a master's degree in social work and a master of public health from BU. And in her free time, and we were discussing this before we began, along with Mike Hugo, she has a passion for rock and roll. that she merges with Healthy Youth Development, and she volunteers with one of my favorite programs, the Girls Rock campaign. So thank you both for being here with us.
Good morning. Thank you so much for having us. We're going to start talking a little bit about theory and then move into kind of how this plays out in practice. And just give me just one moment. I'm going to share my screen. So, thank you. So we're actually going to introduce this topic of cultural humility, which is something that we are introducing in our practice in our community-based work at Cambridge Health Alliance, as well as how to integrate this into all of our care and treatment and services across the system. And while its roots are in medical practice and social work, it's really like cultural competence, something that can be transferred and skills within any of the fields in which that you are all joining us. So it's nice to see some familiar faces from across the communities. And so as mentioned, I do have the background with a lot of youth work, and we're also doing a lot of training now. So thank you again for this opportunity. About a year ago, members of our department had the opportunity to train directly with Dr. Melanie Turvalon, who coined this phrase and published cultural humility. And I'll introduce kind of the tenets about it. And with a real training, we would really unpack all of this and how to really embed this into all of our work. We have a number of community health worker trainings that this is part of now, our volunteer health programs, as well as then interdepartmental and cross-disciplinary. And so named or not, a lot of this is stuff that people may be familiar with, but this really gives us some concepts and a theoretical framework and how to approach this work, whether we're doing prevention work or treatment work, recovery and healing, and so on and so forth. And so when you think about culture, and I invite you all, to make comments in the chat box. I'm used to really interactive conversations, but I'm going to keep it short. When you think about culture, what is it? What are the different things that you think about when it comes to culture? So we'll just take a moment to give some thought to that. So often we think about food and maybe certain traditions, different religious practices, but really, culture manifests everywhere in our lives and in the many different types of identities that we hold, whether we recognize it or not, that the human behavior, the interactions that we have, how we celebrate life, how we celebrate death, honoring, our families, and so on and so forth, the values, the attitudes we have. So I just want to briefly introduce Dr. Murray Garcia and Melanie Turvalon. They published Cultural Humility versus Cultural Competence, a critical distinction in defining physician training outcomes in multicultural education in 1998, really pushing this concept of competence into humility. And, from a medical training background, this idea of competence, has a very, very specific skill level and development and kind of an endpoint and mastery. And when it comes to our cultures and our human interactions, can you really ever have that mastery and maybe have a little more humility, which challenges a lot of the training and the teachings within the medical field and probably other fields as well, and really builds on the important work of social work and really trying to do good care and service and treatment and partnership with clients and patients. So also I just want to share that the foundation of this work, they're based out of Oakland, the Children's Hospital out there. And as this was happening, there was a lot of racial strife and challenges happening within the community that was playing out outside the hospital walls. And while maybe it was also being mirrored in the hospital, it wasn't being addressed, it wasn't being talked about, yet it had tremendous impact regardless of what role you had at the in the agency, and really needed a voice and to be spoken to. And so the other part of this concept is rooted in community organizing and practices in that way. So it really bridges, a lot of the work that we all do in our community work and our health work in the community. So these are the four main tenets, and we really unpack them a lot in the work that we do. While this is we're in a theoretical and brain area, this is really significant heart work that has to be done for all of us to really do good service and care and justice for our communities and the people that we care so much about. So a lifelong process of critical self-reflection and self-critique. And so we are always learning. There's always something new to learn, to understand, and to listen for. This redressing the power imbalances in the patient-provider dynamic. So really having this respectful and meaningful partnership with patients, their families, and the communities we serve. And we really look at where power exists in our lives. Where do you have power? Where do you lack power? And the many different elements and roles and relationships that we carry and hold. And how does that change and shift over time in those relationships and those identities that we have. The third tenet, developing mutually beneficial partnerships with communities on behalf of individuals and defined populations. So again, this respectful appreciation and attitude towards diverse lived experiences, and that the client or the patient, whoever it is, that they have a lot of knowledge and they understand their lived experience and maybe have a different perspective that's going to be very valuable in that relationship development. And then the fourth tenet, advocating and maintaining institutional accountability that parallels the three principles above. So they really felt that it was important not only to have this kind of micro individual level tenet, but that that there must be institutional accountability and that there must be an organizational level developmental process that is ongoing and that parallels the characteristics of cultural humility. And so this is something that, is very current. A lot of institutions and organizations and companies, communities are really grappling with looking at the structures that exist right now, and people are holding them accountable. We see that a lot in the work that's happening in community organizing and so many social movements that are out there. And so kind of what's the difference? I thought I'd include this slide because that often comes up, the kind of how do they parallel? And so again, this learning, always learning, we're all students in life versus this mastery and being an expert. And of course you want, someone performing surgery to have mastery and be an expert in that, but then in the human interactions and then the cultural understandings to continue to learn and understand. So it's really fluid, and that there's not this end point, and that, it's not a linear pathway to this. So it's flexible and dynamic. It's not this checkbox of I understand all of this culture and I know this patient and everything about them. So we have a designed treatment for them, but that it's personal and authentic, and with that really being in partnership with people and with your staff and so on and so forth, which challenges this hierarchy that often upholds the status quo, and understanding that our culture and our communities are always evolving, and that if we really want to do justice and help people, that we have to find a path to equity. And so, especially with regard to culture, holding the stance of humility is necessary, since there's no reason why any of us should know everything there is to know about cultures, including the ones that we identify as our own. And so we're all complex beings. We have our own stories. Our identities are rooted in that story. Stereotypes affect our actions and decisions, including favorable and unfavorable assessments, even how we design, assessments for and collecting data. Our biases are activated involuntarily without a person's awareness or intentional control. And so if you think about in a medical setting, how do these biases influence diagnosis and treatment decisions, and so on and so forth. And so think about within your own field. How do biases influence decisions, and who's at the table, who's involved in all of that design and work and decision-making power, who is not part of those discussions. So we recognize that cultural humility is a journey, many challenges, but we can learn from those challenges, and our organizations, our agencies can also really learn and grow and evolve, especially if it's being done in partnership with the people that are part of the whole, regardless of their title, regardless of where they sit in the agency. Many of us benefit from great privilege. We don't even know that sometimes. And so where do we benefit from that? Where can we challenge that? And so we need to acknowledge our power, our privilege or lack thereof, and really be open to learning. And so why humility? I just, want to make sure that we understand, taking that step back and that we don't always know everything. I do so much youth work, and it's a lot of learning and listening, even though, I've been through that age group. I'm not in the current age group. And so really understanding their life experiences and what's happening can really benefit everybody better. And so not being arrogant or prideful, all-knowing, and really challenges a lot of the medical training and a lot of the training many of us have overall in the fields that we work in. And so then just one final thing. So really thinking about the ground on which we stand, and many people have come before us and will come after us and have done a lot of work that we should honor and recognize. And this graphic has been put together for our cultural humility training, and it always asks the questions: who's missing in these images? Who's not at the table? Whose voices are not heard even in these stories that we do know? And also what else and where else can we go for all of these movements, and how can we really support and honor that history, the work that leads us towards equity and justice, and we like to say transformation. And so I have a little quote I'd like to read just related to this. The purpose of our understanding in cultural humility, this model or any model for social justice is to move from ideas to action, from hope to change, equality to liberation, and mirroring the transformation of the butterfly. So I am just going to pass things over to my colleague, Dia. I can share this slide as well as a video that also unpacks the full story with the doctors talking about how they came to this. It's really powerful, it's really compelling, and still very current and relative. So thank you so much.
Thank you so much, Amy, for that wonderful presentation. I had a preview, and I think the way that you describe cultural humility is really unique and beautiful. So thank you for that. Thank you all for having me. I'm here today to speak about what we've been seeing on the linguistic minority teams at Cambridge Health Alliance, of which I'm the program leader. As many of you may know, we serve a large immigrant and multicultural population at CHA, and we have 4 linguistic minority teams that serves the Haitian population, the Latinx population, the Portuguese population, and the Asian population. And I would like to just share a little bit about the work we've been doing in regards to substance abuse and what we've been seeing, and mental health more broadly, especially in the context of COVID. I'm sure, as you all know, the communities of color and immigrant communities are really facing the disproportionate burden of COVID in multiple ways, which I can tell you sort of what we are seeing on the ground. Let me start with just our general principles, which I think echoes what Jamie has put out, laid out in so well. The teams really believe in a human rights approach to health, that all of our patients and all individuals have a right to health, while they also attend to social justice issues in their work day to day. What does that look like? In addition to our patient care, we have a lot of relationships with the community that serves our patients. So we do radio programs in the language of care, we do outreach, and we work with other community agencies that support our work with our patients. as I've mentioned, the disproportionate impact of COVID we've seen in different ways. And I will give some examples just to sort of ground it in our reality. The Haitian population in particular has been decimated by COVID, in part because of many of our patients are in the front lines of the COVID pandemic. Many of them work as PCAs, many of them work in nursing homes with inadequate protection. So we have just seen, as they are working very vulnerable and unprotected jobs, more and more of people losing entire family members to the pandemic. What we're seeing on our Asian team, for example, as another example, is a lot of discrimination that the patients are reporting, hate crimes, being, accosted on the street, being blamed for the virus. So that's another example of what we've been seeing. The Portuguese community is similarly impacted. We also see a large Brazilian population in that clinic. And again, they're in very vulnerable jobs, very anxious about the outcome of the election. And so this is what we've been, and really are struggling with even less access to the benefits that they had before. In addition to what we do for our patients, we have been offering, what we try to do is also offer support for the groups within and outside of CHA that work with our population. So one example is offering workshops of support and traumatic stress, secondary traumatic stress to, for example, our medical interpreters and other immigrant agencies that work with our population that Mary and others from our community health improvement program know well. One of the more tragic things that we've been hearing from our patients is a real struggle around burial related to COVID, not having finances to do so, not being, obviously with their families. And so we've been trying to raise funds and support people in this endeavor, and has been, I think, the community agencies that work in the true front line, interpreting and things like that, have also borne the brunt of hearing these traumatic stories with patients. So we have been trying with our foundation to disperse any resources we have to, I think somebody said, I think it was you, Marion, that this was substance abuse is a disease of despair. And I would say what we also see in our population is the diseases associated with poverty and migration. What has been interesting in terms of the data we are seeing from our clinics, on the one hand, of course, we can't do in-person visits in the way we have anymore. And what we're seeing with our communities of color is that they have even less access to sort of in-between levels of care regarding substance abuse. So they might be able to get into inpatient or dual diagnosis levels of care, but everything that was there in between, the access in terms of the language of care has really diminished. And so that's something that we're very attentive to. We can get people in for outpatient care, we can get people in for inpatient care, but those things in between, those I think have fallen down a little bit in the context of COVID. So what I would say, on the other hand, just to offer a positive, positive response to what we've been seeing, is we have, in some ways, being able to do things telephonically and virtually has improved patients' access to our care. As you can imagine, many of our patients need to work, and for them to come to an appointment in the Department of Psychiatry somewhere, or for methadone, for other things, sometimes necessitated them to take a day off work, and travel and put themselves at risk in via public transportation. What I'm hearing from the teams is now people are able to step away from their work and have an appointment on the phone. And we have found ways to get letters and other things that they need for eviction or other types of support to them. And so in fact, our volume in terms of who's able to access us has increased. And I think we all feel that access is incredibly important and doesn't mean anything if we can't offer something truly on the ground. And so I think in some ways the virtual world has enabled people to not have to suffer financially to also access service or put themselves at risk just to travel to the clinic. And I think our Cambridge work moved very quickly to a telephonic model, given how COVID kind of hit us like a tsunami, I would say. And I think that has actually been quite effective for our patients. So I will pause there, and I'm glad to take any questions about our programming.
Yeah, this is Nora from the DA's office. I was chatting with Jamie about it, and this might seem to be a really unsophisticated question, but is the overlap between communities of color and linguistic minorities also connected with class and economic disadvantage? I guess I was kind of wondering about the relationship between linguistic minorities and this notion of cultural competence and humility.
That's a great question. I think it can, not always, but certainly at CHA it is. As you know, we have a commitment to working with the poor, the severely mentally ill. So the patients that tend to come to us are disadvantaged on multiple levels. And I think we are unique in offering, especially linguistically based care, which I think we are unique in having such a large service. And people know about it. So even people who live in, quite far from the clinic come to the, for example, to the Haitian team because it means something to them. I think that there's an entire team devoted to that population rather than, I think, other systems where, it's sort of pockets of care where there may be one provider, but this is an entire team that's not just for service, but also trains the next generation, residents, psychologists, social workers, nursing in particular care for individual communities.
Thank you. Thank you.
I'll just look at the chat to see if there's any other questions at all. I'm happy to.
There is a question here. Would love to learn more about the cultural humility framework from my colleagues at large general, resources or books, articles, websites that you could share.
Yeah, I'm happy to share through Nora if you want to send out both the slides as well as some additional leads for the work. And definitely there are folks offering this training through the state in different places, as well as, we were trained with a whole team of folks in Archana, which we were very grateful to have some funding to bring Dr. Turvalon to town. So there are a number of folks out there that can also bring the resources right to you locally.
Yeah, and I'll be happy to, I'll put things in my follow-up letter. I'll make sure to have all the resources that I can provide. All right, wonderful. Other questions?
Thank you so much to both of you. Appreciate that. Can I have a question? I ask a question. Is this the kind of training that you would offer to something like our office, the DA's office?
Yeah, absolutely. I do know that some colleagues of ours in Somerville are doing this training with the police departments and so on. So absolutely, it's something that, I think is transferable across fields.
All right, well, that would be great. Maybe Nora can facilitate us setting that up.
Thank you.
Thank you both.
It's such a different way, a profoundly different way of thinking for professionals. Because whether we're lawyers or nurses or physicians or PAs or whatever, we go in and we're going to fix it because we know everything. And clearly we don't. And maybe the pandemic has shown us even more so that we don't know everything.
Well, but also to the point about how much this ability to be virtual has made an enormous difference for people. As much as we're all complaining about spending the day on Zoom, it's true that this has had some really good outcomes for people. And also, I don't think you can underestimate the fact that, especially in some communities, even being seen going in and out of some place that might give mental health treatment is an issue. So to be able to sit in your kitchen and do that is a completely different story. So thank you. Thank you both. Now, our next presenter comes to us from Casa Esperanza, and many of you know the center, which is a bilingual and bicultural behavioral health center that specializes in serving the Latino community. And their mission is to empower individuals and families recovering from addiction, from trauma issues, mental illness, and other chronic medical conditions, as well as homelessness. And they offer a really comprehensive, integrated care to address all of those issues. And we're fortunate today to have Shannon Barrett with us, who is the program director. And the program itself is located in Tewksbury. And Shannon's been in this field for about 8 years. She's worked in residential settings for the treatment of substance use disorder. And she's also worked in outpatient treatment programs and is on the board of directors of a small nonprofit in Lowell. So Shannon, welcome. Thank you.
Hi, good morning. Thank you very much for having me here today. Great presentation, and what a lineup to go from cultural competency to a program that specializes in culture and language and barriers that people are seeing in their community. I'm having a little hiccup here, so bear with me with my technical difficulties. I'm actually logged into 2 different computers to try to get my camera going and also to see if I can screen share. So bear with me here a moment, and I'm going to see what I can do to try to share my screen.
Shannon, if you want to send me your presentation, I can screen share it.
Okay, I'm hoping that worked. Did that work? It did not work.
Oh, there you go.
I'm going to send it to you,
Okay.
and maybe we can just circle it around afterwards, because yeah,
Absolutely.
I'm logged into multiple devices here, and technology is really, I mean, through COVID, I've had the blessing of coming on site to work to not have to learn all of this technology right away. So I'll send it out afterwards, and
Okay.
if there's any questions that I can answer while I'm here, for sure. So yes, my name is Shannon Barrett. I am the program director for Casa Esperanza CSS program located in Tewksbury. People may know us or recognize us by the name of Conexiones, which means connections, and is really about eliminating barriers to treatment here in the community. We're new in the sense of being in Tewksbury and Middlesex County, but not in the sense of programming that we offer. So CASA was founded over 30 years ago and was created really by a men's residential program that's located out in Roxbury. It's a 30-bed facility for men either re-entering community from incarcerations or mental health facilities. And then there's also Latinas and Niños, which is a residential programs for women and children. Again, serving women either reconnecting through DCF or family, whom also suffer with the disease of addiction. We do have an outpatient program, Familias Unidas, and you'll hear me refer to it as FUOP, which is our little acronym for it, but it is an outpatient clinic right now that is operating 100% remote through telehealth services. What makes most of our programs different is the fact that we offer all of our services in both English and Spanish. So it really is about eliminating the barriers to treatment for people who English is not their primary language or their first language. We share in the culture of the Hispanic Latino community. We share the music, the food, the spirituality, the religion, the language, and really pride ourselves on, you know, behavioral health and integrated care being a human right and not something that people have to fight and struggle to get access to. Our FUOP program, which is our outpatient clinic, is actually partnered with Boston Healthcare for the Homeless, and they offer services from psychiatric care, again, bilingual psychiatrists to get mental health treatment, from mastered level clinicians, LICSWs, LMHCs, different LADACs, different people with different license to specialize in what the person is presenting with. Through Boston Healthcare for the Homeless, we have been fortunate to be able to offer and open a Suboxone clinic. Again, primarily focused in the Hispanic Latino community with the language of being Spanish and you know, being available for people who, again, may not be able to seek services in any other location due to language barriers. So that's CASA kind of as a whole in a nutshell. And I'll circle back to CSS, which is the reason I am here, the program that I know and love. And so CSS is, your typical 10 to 14 day program. Geographically, we're located here in the Tewksbury State Hospital. We share the Saunders building with a lot of the other DMH, DPH facilities here. So we are located here in Tewksbury Hospital. Again, your standard CSS, 10 to 14 days. The primary focus here is substance use disorder. However, about 96 to 98% of our folks coming in have either co-occurring disorders or, a huge array of different medical health, physical health, psychiatric health concerns that have not been addressed. All of our services here are also bilingual. Everything from group counseling, group therapy, individual counseling, individual case management. Our nursing staff is all bilingual to be able to offer education and resources in languages that people feel most comfortable. What makes us a little bit different besides the language is we are probably one of the only CSS units in the state that is not accompanied with a detox service. So we are, a standalone CSS level of care. However, we do have the residential services as part of aftercare options. But I always think that's interesting to mention because when you think CSS, you think a continuum of detox, which we're trying to break that barrier as well. We do have a nurse practitioner on site who specializes in psychiatric conditions. He is also bilingual, which is mandatory pretty much in the programs that we offer here. So being able to really meet people where they're at with their sets of needs and speak the language that they feel most comfortable, share the culture that they feel most comfortable. A lot of our mission and philosophy here is really about patient needs, patient care, and patient-centered approach. So, our folks will come in and maybe they have a diagnosis of alcohol use disorder, but they also have diabetes or heart condition. And, for some reason or another, they haven't been able to be treated in their community or they're not stabilized in their community. So we take great pride in that stabilization process, not only with your substance use disorder, getting you connected to MAT services, getting you connected to community services, to continued residential services, but also to treat the other conditions that you have coming in, the depression, the anxiety, the bipolar, the schizoaffective, and also the physical health, the diabetes, high blood pressure, high cholesterol. We really want to take this multi-pronged approach and really see the whole person and treat the whole person. We know from best practices that we have to open the lens a little bit, that we take the disease model of addiction and really try to get the whole person engaged in treatment, spiritual, mental, emotional, physical. Some of the other things that are somewhat different here than what I've seen in my experiences kind of across the board in different levels of care is the staffing pattern that we hold. And so I always think it's really interesting when we have everybody from nurse practitioners, psychiatrists, MDs, all the way through the continuum of people who are in school right now for their LADAC or associates or whatnot. So I always think that that's a great mention to bring to the table. A bulk of our staff are also people who are in recovery, who have gone through recovery coach certifications, have gotten their degrees, have advanced themselves professionally in different ways. So I always think that that's a great kind of, elegant conversation to have, is that you see people professionally in all different parts of their journey and their development and their growth. And so that's what we like to bring to the table for our patients, is that it really is about development. You may have a substance use disorder, you may have a physical health condition, a psychiatric condition, but we're trying to normalize that. We're trying to show you that this is not the beginning, nor is it the end. You are in your process, you are in your journey, you are going through your continuum of care, whatever that might look like. So individual treatment across the board for everybody who walks through our doors. We are openly accepting referrals. We have an amazing admissions team made up of our admissions manager, clinical supervisor, and myself. Our nurse practitioner will get involved with people who might have some sensitive medical conditions or psychiatric concerns. But we openly accept referrals 7 days a week, 24 hours a day, holidays, nights, whatever have you. On our website, you'll find a big bulk of information, how to refer to us, what our treatment, different levels of treatment options are, and how to get those referrals in. All of that will be on the PowerPoint, and then I'll send a quick one-pager to kind of summarize what departments, what information you might need if you would like to make a referral. You know, COVID has not stopped us in any way. We continue to serve patients. We continue to take patients in. You know, our staff is a great team of people who are dedicated to the work that they're doing. You know, it's always great, whether it's external meetings or internal meetings. I always get this big cheesy smile when it comes to the team that we have here, because it really is a devotion of individuals who are here to serve their community and the people that they take pride in seeing every day. So COVID has not stopped us. It probably will never stop us. We'll continue to serve the patients who are seeking the treatment. Our unit is co-ed, so we do have a 32-bed facility. We serve both men and women. We have the capacity to treat 12 women at one time and 20 men at one time. So if you think our, you know, a regular hospital ward or unit, you have the nurse's station, and then you have one wing of rooms and another wing of rooms. That's kind of how our unit looks here. To give you a little visual. So it's completely separated. There's no integration of the men and the women. Essentially, it's two different programs that are running simultaneously, offering these services. So I know I've said an awful lot of words. I don't know if anybody has questions or if there's points that maybe I didn't bring up that you might want to bring up as well, but yeah, I'll stop talking for a minute.
So Shannon, you mentioned at the beginning that you don't have a detox component. Can you explain, because I'm not in the industry, as it were. What is the why is that, and what's the difference between that and a different kind of a model?
So I mean, CSS essentially is a step-down program from a detox or any type of medical, you know, hospitalization. Medical detox is much different than what a CSS can do or what it can be looked at as. Now, we do offer MAT services right on site, which helps in the continuum of withdrawals. However, we don't do any medical withdrawals or detox treatment here on site. And the big point is that a lot of detoxes also have CSS level of care, whereas we do not. We have one facility, which is CSS, and then we have the residential and outpatient services. Other programs might be the opposite. They might have detox services with CSS and TSS, whereas we do not. And so it's a good point that I like to bring to the table, because I like to mention the fact that we are not a detox service. We cannot offer those services, but we are essentially a step down from that avenue.
Are there geographic limitations for referrals, or would you take people from anywhere in Middlesex?
Yeah, so the whole state of Massachusetts. We've been here in Tewksbury for about 3 years now. A big bulk of our referrals do come from the Boston area, but I think that's just because that's where it's detox heavy or hospital service heavy. But, you know, we're here in Middlesex County for a reason, because we know our community needs it. We know our Hispanic, Latino, people of color population need the service that we have here. And so, you know, my role now is kind of getting out in community and really talking with folks who are in the community, who are seeing our population, who struggle with language, and let them know that we're here.
So I would just was noticing, thank you, Jason, for popping up here. And in the chat at AdCare, AdCare refers to Casa Esperanza once detox. So it really is this continuum and partnership. That's helpful. Is there a waiting list for your program, Shannon?
So there usually is a waiting list. However, it's so quick. The turnaround is, minutes and days and hours. So we might have a waiting list of 30 people, but that might change in a day. And so it's always good, as soon as there's somebody who's identified who may want to come, the sooner you send the referral, the better, so we don't lose those days and hours.
I see Dr. Armstrong has a question, she said she sees patients at Newton Wellesley from Waltham with multiple needs and few resources, and it's difficult to travel. Are there ways to support patients for transportation, and either financially or otherwise?
So I know that not too long ago, there was a presentation about a service, I think it built out of Lowell or Middlesex County.
The drum driving.
Right. And so we've utilized their services for some of our folks. We have a driver here at CSS, and the purpose of our driver is to bring people to their next level of care. If there is, a tough situation where people are referred to us, but they absolutely have no means to get here, then it's an individual basis. We try to work it out. I know for most of our programs in Roxbury or the Boston area, it's tough for folks in this area to get to them. And there's, probably a permanent push on some of the telehealth services that we offer for an outpatient base.
Mm-hmm. And as Miriam just mentioned, Mighty Drums Rides to Recovery, Joni just put their link in the chat. And they have a great program where folks can get rides using Uber. Terrific.
Do you have their number?
The Mighty Drum folks?
Yes.
Their email is right here it's in the chat, jmaffei, JMAFFEI, at mightydrum.org. And then the website is also there.
Thank you.
Anybody else? Questions? Sharon?
Thanks so much. I appreciate the opportunity here this morning.
Shannon, thank you.
Thank you. Thanks for the work you're doing.
All right. And our next presentation brings back once again somebody who's been a presenter to us before, Mike Hugo. Many of you know Mike. He's very active in Metro West, and he's here today in the context of his work with the Mass Boards of Health. And we thought it'd be helpful, given where we are this deep into the pandemic, to hear what's happening in local communities on the Board of Health front. Many of us are counting on that for lots of things around addiction and recovery space. We wanted to see what the impact has been of, I guess, almost 7 months. As I pointed out with Jamie, we already were teasing Mike about his having opened in Chicago and dedicating a verse of a song to Nancy Pelosi in his rock and roll world. So we can segue right into that. So Mike, thanks for being here again.
You made me into a tough act to follow there, Marian. I'm going to put up a slide presentation, and I'm going to kind of crash through it because as I'm sitting here and looking around the pictures of who's in the room, I don't want to be teaching something to everybody here or preaching something to everybody here that they already know. So I'm going to crash through the slide presentation rather quickly, and then I want to talk to you about what's really happening, what the real life is in the world of public health. And I'm going to actually go to some testimony that I've given to a legislative panel a week, 2, maybe a month, maybe I don't know what day it is anymore, let alone what week. But Let's see here. So I am sharing, is that right? You
Yep.
Okay, so I want to go to a bigger presentation here. I'll do this. Okay, so we're going to talk a little bit about, I'm going to get through some of the issues that have changed, I think, from a public health standpoint with COVID. Right now, I think that the biggest issues right now, and Dia did a great job of laying this out, are the issues of anxiety and grief and isolation and what that's doing to people who do not have issues of dependencies, let alone people who do. The people who are facing the issues of drug dependency are completely challenged with totally unique, awful confounders, being stuck in the house. Some people are not able to get to their support mechanisms. They're isolated and being sheltered in place. They can't make friends. They can't be with their friends for purposes of mitigating the dangers. There's nobody there to administer the Narcan to them if they need it. They're dealing with unstructured time, which might be the biggest enemy of somebody with a substance use disorder. The whole thing is confounded by the fear of going to a hospital to seek treatment where COVID is rampant. I think that unless you're coming in with COVID issues right now, you're being treated as a second-class citizen even today in many hospitals. So it just is confounding all of the bad issues. One of the nice things that's come out of it is that we started to rely on telemedicine for everything, including treatment of addiction disorders. And I think that some of the steps that have been taken to increase the ability to stay home and be treated at home, just like what we're doing right now with Zoom. I wonder how many of the meetings we all go to in the course of our day that we used to get in the car and go to. I wonder how many of those are going to, after COVID, I wonder how many of those are going to be programs that we're going to be picking up on this way and not having to go places. The same thing has happened in the world of addiction treatment, that right now the BSAS changed their regulation, allowing twice the number of methadone doses to be able to be taken home. There are lockbox provisions and things of that sort. And interestingly, since they've done that, there've only been 19 reports of lost or stolen methadone. So it's sort of opening just a whole new awareness in treatment centers and in medical centers and in the world of public health, that some of the things that we never thought we would ever be able to see, we're doing right now. We're actually doing things that were just unfathomable before the Zoom era and before COVID. You know, if somebody said Zoom back in February to you, you would have thought they were talking about a children's TV show, not the next way of life that we're all going to be living with. There are some issues, though. Well, one of the interesting things is that civil commitments now are down by 50% since COVID. But as I pointed out earlier, the harm reduction conflict is that people, number one, they can't be with the quote bad influencer friends, but on the other hand, they're doing things alone that are highly too risky to be doing alone. So what we're seeing is really the disparities that have been discussed so far today. They're getting wider and wider, and we need to deal with that head on. So this is where I really want to concentrate. And I actually, people have to understand that the local board of health is not getting any bigger. There's still the same finite resources that are available. And that's creating issues where, number one, you can't have your whole staff in your office. It's not big enough. So people are working remotely, but they're still having to do things like site plans for new projects, and they're still out there doing all of their inspections, but they can't come into the office, they have to go home. I watched last night as the city of Framingham City Council started to pick on the Board of Health because only half of the health inspectors are in the office. Well, that's because they have to distance, just like everyone else, and they're out in the field, but that didn't get mentioned. So here's where I want to actually turn to some testimony, and I might appear to be reading it because that's what I'm going to actually do for some of it. I had testified a couple of weeks ago in front of a legislative panel about what's going on in the world of public health. And I think it's more important that the people who are in this meeting right now hear some of the substance of what that testimony was, because a lot of you don't understand what's happening and think that you can go to the Board of Health like they're Superman. And they're not. They're human beings, and some of them are about to break. They're very close to breaking. We've had 4 or 5 health directors in Massachusetts who got up and walked out of their office in the past 3 weeks and just got up and walked out. They didn't give notice. They didn't tell anybody where they were going, and they never came back to work. And it's getting to be at that level. My record is 1:30 in the morning that I got a call from a health director in a town. I've spoken to people at virtually every hour of the day and night. I got a call from somebody and he was near tears. He didn't know what to do. He didn't know how to enforce. He couldn't find anything in the governor's regulations at that hour of the night and just needed to find out real quick, what can I do? Hence a 1:30 a.m. phone call. So here's a little bit of the testimony that I gave, and I think that it's really to the point. Little regard has been paid as the governor has entered his 50 executive orders for the health and well-being and functionality of our public health system. Of the 50 executive orders issued by the governor, 30 of those orders call for Board of Health action. Of those 30 Board of Health orders, 20 of them were issued and became effective on the same day. The strain and stress that this has put on public health has been met with perfunctory thank yous by various government officials. However, the situation has become untenable and unsustainable. In the workforce, there's an expression, thank God it's Friday. In the world of public health, for the past 6 months, the expression has been, oh my God, it's Friday. We've all come to dread the governor's Friday announcements. If you actually watch these announcements the governor does, they all happen on Fridays. Everything that happens to health happens on Fridays. So I said, we've all come to dread the governor's Friday announcements, which too often include his most major initiatives that are to be enforced and implemented by local health, effective the following Monday. Among the 20 same-day orders, on May 18th, the governor announced his new phased reopening program to be effective on that very day. Imagine that. Imagine working in the world of public health and finding out, like everyone else, for the first time when you're watching the governor, that today we're going to start reopening the Commonwealth. That's what happened. The most daunting order of all was the phase 2 reopening order announced on Friday, June 5th, to be implemented on Monday, the next business day. 10 days later, the governor assured us that part 2 of phase 2 would be sometime down the road. And just 4 days later, that following Friday, he rolled out his plan for the second part of phase 2 effective the following Monday. All of these plans by the governor were made upon the advice of his reopening advisory board, which consisted of 19 members, including the Commissioner of Public Health as the sole voice of public health. And if you're a commissioner in this governor's administration, you have to sort of follow the governor's line. So that became an ineffective voice for public health. Okay, so in addition to that, there were 10 corporate CEOs and officers, 2 mayors, a cabinet secretary, a college president, and a doctor. Our healthy reopening was planned by a bookstore owner, an airline president, a weapons manufacturer, a restaurant chain CEO, and a clothier, and a software designer. That's who reopened the Commonwealth. I don't think that's good public health practice. The result, a week later on May 7th, when all businesses except essential services were closed, lines were building at food pantries and food distribution points to record lengths across the Commonwealth. While it was impossible to get a license plate for a car, while recreation venues across the Commonwealth that benefited Black and brown people, like playgrounds, were closed, mysteriously golf courses were open so that the folks who were least affected by COVID-19 could continue their routine luxury life. Of course, the vulnerable, mainly Black and brown workers had to return to maintain the grounds of the golf courses so that others would be able to play their round of golf. There could be no more strong statement of social, racial, and economic inequity than this one shining example. The stress is on the workforce, and here's, I'll go off script here and tell you that things have become so bad, including the people I just discussed with you, before I started looking at this speech. Things have become so bad that the Department of Public Health now has a psychological services agency, which actually, as we're speaking here today, is doing a webinar for Board of Health members and for health workers, public health workers. And the Commonwealth will pay for 3 psychiatric visits for anybody who's in the public health arena. That's how bad things have become. So I'm not saying that public health is paralyzed, but what I am saying is that there are so many stresses that are being put on the public health system that it can't continue the way it is. One of the problems is we have 351 boards of health across the 351 cities and towns, where other states have North Carolina has 2 health departments, one in the east part of the state and one in the west part of the state. No municipal health boards. Massachusetts is the only state in the nation that has $0 coming from the state government going to local boards of health. It all comes out of your municipal budgets. So there's some things that we're working on right now. We're working on trying to change that. We have something called SAFE, S-A-P-H-E, the SAFE Act, which has passed, and now we're working on SAFE 2.0, where we're going back to the legislature, and we're going to ask for 50 to maybe 75 $1 million, looking for the ability to start to decentralize and share resources across the Commonwealth.
Mike,
Yeah. Yes.
hang on, this is Nora. I just wanted to, one of the things that I think we've seen nationally is all of these, the lack of a federal program and federal guidance, right? So how do you see decentralizing these decisions as working? Like, if the Arlington Board of Health and the Belmont Board of Health made totally different decisions, well, I can just walk over and I won't know. So how do you see that working?
Great question. What the SAFE Act does, one of the provisions of the SAFE Act is that it mandates uniform training for all health workers. So the Board of Health members will have to go to classes to get basically certified so that they're all working on the same training basis. All of the health inspectors will have minimum competencies that they have to take examinations for and go through courses for. And the health directors have the same kind of a pattern too. So the idea is to get everybody to be thinking on the same page. Now, you're right, because in Framingham, I remember years ago, we had an issue involving a tattoo parlor that was giving tattoos to 13-year-old girls and putting them in some places that the parents went crazy, and so did we as a Board of Health. So simply what the tattoo parlor did was they moved to Ashland after we passed a very, very rigorous standard. So what you're saying, Nora, is absolutely right on target. But what will happen is that, for instance, right now, Framingham, Ashland, Natick, and Hudson are sharing in their MOPSI grant to do the trainings, and that's being used as an example. I'm working right now on a project with Martha's Vineyard. Martha's Vineyard has 6 towns, 6 boards of health, 18 members of the boards of health, 6 health directors. One of them won't talk to any of the other towns for any reason about anything. And my mission is to get on there and combine them into one. And COVID has worked for that, because what I'm doing right now is, if you look at Edgartown or if you look at Oak Bluffs individually, they look pretty good. But if you take the whole statistic for the island, which is now in the gray area on the map and has been all along, which means it's tiny numbers. But if you combine the 6 municipalities, we may well, once we are able to do that, we may well be seeing Martha's Vineyard as a yellow, a green, or a red, and it's very likely it'll be elevated. It may not be red, but they're missing out because they're not looking at the aggregate of what they have on the island. If you look to Western Massachusetts, we have some regional health districts there, and the way that works is that all of the boards of health work together on various projects, and they have one health director for the region, but each of the cities and towns has their own, but they work in harmony. And so we're going to be trying to roll that out. Right now, Lexington and Belmont, we're trying to have Lexington and Belmont get on the same page on things, because there are weaknesses in either of those boards of health that when you combine them together will become major pluses. So there's a lot of this balancing going on right now. But COVID has kind of thrown the stopper in a lot of this. A couple of things that we're doing in Framingham is we have the post program, which is it started in January, just before COVID happened, and we're starting to we're doing outreach to families after an opioid overdose incident. And we're going into the homes in Framingham, and Kelly Joseph is doing amazing work on that, and trying to further harm reduction for the family, doing education for the family, and on-the-spot access to naloxone. Our Metro West Health Department naloxone program, which is those towns, Ashland, Framingham, Hudson, and Natick, we've given 600 individuals training and doses of naloxone, and Kelly has gone into the businesses to give services there, and has gone to 40 businesses in this area. And then we have an initiative to label various businesses as recovery-friendly workplaces. It's an initiative that will recognize businesses that will hire people who are in recovery, and the Board of Health in Framingham is, through Kelly and Sam, is reaching out to these businesses and offering services, training programs essentially to the management, so that they will know how to deal with particular issues that may come up with people who have drug dependency issues, and to give a reward as being recognized as a family-friendly, a recovery-friendly workplace. Framingham right now has an extremely wonderful citizens group, which is run by Kathy Miles, who I think is no stranger to a lot of people here. In fact, I'm not sure she may even be in attendance right now. I didn't look at the whole list. But the Framingham FAST group is a family group that is recognizing and destigmatizing to an amazing degree all of the issues that confront us. And so it's now at the point where some of the businesses are going to the Board of Health and saying, I want to help out, I want a piece of this. And I think that a lot of that has to do with the Framingham FAST organization. And finally, we have the Pediatric Scope of Pain program, where we've reached out to over 700 medical professionals across the state. Framingham is doing this with BU School of Medicine, and we're reaching our population of doctors at Framingham Union, or whatever it's called this week, Metro West, I think it is, this Metro West Medical Center. And we're reaching out to talk about prescription, because you know, the issues, we all know the issues that confront children who are high school athletes don't end when they get back to the classroom. A lot of the issues continue on with not just with neurologic injuries and things of that sort, but there's too many of them are going back depending on drugs. So this is something that's being dealt with on the local Board of Health level. But I just want, you know, I apologize for veering off my slides, but I think it's important that people understand that it's a fragile system. We have some cities and towns. We have some towns in Framingham, not in Framingham, in Massachusetts, I'm sorry, where the whole health department is a health director who does inspections, who has to go to meetings. We've had, I know that my record is 11 Zooms in one day, and that happened last week. We're all living on Zooms. We have so many issues that are coming out of the woodwork having to do with COVID, but at the same time, you know, I'm applauding Framingham because not just because I live here, and not because I was 15 years on the board, but I'm applauding them because they're able to fund the positions that make it so that we're still able to deal with issues of opioid dependencies on our streets while we're dealing with COVID. And I think that it's just a town by town thing. And hopefully, you know, after the SAFE Two Act passes, hopefully we'll be able to see some uniformity across the state in the way that public health is delivered. I hope that addressed what you wanted, Nora and Marion.
I know that there's really been a question about how our local boards of health are balancing their mission. And it's clear that it's incredibly challenging, as it is for many of our local agencies and our local organizations. But when their mission is so directly affected, it's a challenge. So thank you. Are there any questions? Okay.
Thanks, Mike. Thank you.
Thank you. And my slides are available. Nora, do you want to distribute them?
I can do that. Yes. That's great. Thank you.
Thank you.
All right. Opportunity for anybody to share what they're doing, events you have upcoming. Anybody have any news to share?
Yes, if I could talk for a quick second. I wanted to actually thank DA Ryan for appearing on my segment of America in Crisis, Breaking the Cycle of Addiction yesterday. It was filmed in Movement Public Media, and actually the entire interview was about the accomplishments of this very task force we're on now. In fact, I see Joe and Joni Moffitt, who have had past guests on the show, are on the call right now with us. So that'll be coming out shortly, and I'll get the link back to Nora Mann so she can distribute that to the members of this task force if they'd like to see the amazing job that Marion did representing the task force.
Thank you. Thank you. Anybody else? Things coming up?
Marianne, it's Bill. If I could just mention, on October 24th, on Saturday, we are having a winter emergency survival backpack day at the Recovery Cafe. We're going to be giving away about 100 backpacks that have warm blankets, gloves. We're doing it with a local Rotary. We've had amazing response to it, and a number of people have donated. We have little medical packs in there and things to help people on the streets, to help them survive and get through the winter and be safe. So we have 100. If you have people that are in need, we can send them and get in touch with me. But the live event will be on October 24th at the Recovery Cafe in Lowell.
What time is that? What time, Bill?
We're packing, Rotary and our team are packing the backpacks from 8 to 10. And we're giving them away from 10 to noon.
And you're staying 6 feet away, right? Sorry, I had to do that.
What's that?
You're staying 6 feet away from everybody, right?
Oh, it's absolutely 6 feet.
Yeah.
We're cautious. Thank you, Michael. We're very cautious about that. So our biggest fear is that we're going to have people lined up down the street. So it'll really, in the end, be by invitation and by time. So we'll separate the group. Most of the people, I think, will come from the shelter and other places. But yeah, 6 feet away. Absolutely. And masks. No one will get a bag without a mask. We also give away free masks too. So.
Great. Anybody else? All right, so this is my preview of coming attractions piece. Next month, we're going to get an update from Sergeant Ed Berman from Ashland. Many of you know Ed. He's going to talk about the information being gathered by the Central Incident Management System, or SIMS. And some of the things we're going to focus on about, and I mentioned it earlier, the increase in the use of drugs, all substances, including alcohol. You know, we've heard a lot about the businesses that are suffering during the pandemic. You'll be happy is the wrong word, but certainly I think informed to know that alcohol sales are up by 27% across the Commonwealth during the pandemic. So that does not bode well. And we're also going to be having a conversation with several local police departments about the response using clinical social workers when they make a 911 call. Obviously, lots of our conversations over the past few months have been about de-escalation, what happens when you're going out to a house you've been to many times before where you know there are mental health issues, how can we, or a drug issue, and how can we be best prepared and have those resources. You know, lots of our departments, one of the things you'll hear is lots of our departments, even who have social worker capabilities, may have it from 9 to 5 or 10 to 4 or something during the day. We all know these things happen in the middle of the night usually. So how can we expand that? What's available for officers that are going out there? So we will be talking about at least those two things, perhaps another topic, and we thank you for being here. We'll schedule our meeting, our next meeting again by email once we've gotten our speakers together. So I thank Nora for making this all work, Megan for helping us with this morning, and thank you most of all for everybody being here. So enjoy the long weekend and be safe. Thank you all.